Great. Well, welcome everybody to this month's Dunlevie lecture. Just a few center updates. The Dunlevie MFM Center has been designated as a community engagement hub by the Office of Community Engagement, and so we'll be joining 160 community engagement hubs across Stanford. This should advance our center's mission with the engagement, the training components, and the partnerships, all of which also are supported by our Center of Excellence grant from the NIH. So congratulations for everyone who worked on this. And congratulations to Dr. Virginia Nguyen, our very own, who was awarded the MCHRI Visionary Leadership Award. Dr. Nguyen received this award for her work in reproductive, perinatal, and stem cell biology research at the 8th Annual MCHRI Symposium in October. So hearty congratulations to Virginia.
It was an honor to receive it.
Congrats.
And just a heads up on our next center meeting, our guest will be our very own also, Dr. Elliot Main, and he will be discussing combining AA-NHPI populations into a single category hides major disparities in perinatal outcomes. So please be sure to join us for this lecture. But today I would like to have Dr. Yair Blumenfeld introduce our honored guest, Dr. Nathan Fox. Welcome, Dr. Fox.
It's really a lot of fun to introduce Dr. Nathan Fox, and from here on out, I'll just call him Nady because it's hard for me to call him Dr. Fox. I first met Nady, just to give you an idea, when I did a sub-I at Mount Sinai in GYN oncology, and Nady was the intern. And so we met each other at like 5:45 to set up the paper notes, of course, that you did before rounding. So I've known Nady since 2001, so I guess that makes it like 25 years almost now. And he was just a superstar chief and mentor, and probably one of the reasons I went into MFM too, because he knew he was going to do MFM from the get-go. He has been just a spectacular, well, he is a spectacular clinician and researcher. Just to give you an idea, not to discourage people, but he ended up when I looked conducting about or publishing about almost 20 manuscripts in his fellowship. And then since then, he has, around, let's call it 200 ballpark, give or take 20 publications. He's on the editorial board of the Green Journal, and he's been on there for a while, and really just a spectacular person. And he makes the rest of us look bad because he's just so friendly and personable and outstanding and efficient and smart and technically skilled. So when we were thinking about who to invite, I had no doubt I needed to invite Nady, and particularly to talk about twins and intrapartum management of twins, because there's a lot of discussion that we can have on twins, and we did that last month, Nady, by the way, with Tony Odibo, who spoke to us about growth and things of that nature. But Nady is really, I would argue, the expert on intrapartum management of twins, not just because he's published, a ton on it, but the data that they use to publish on intrapartum management of twins is from their practice. So he's not publishing, large data sets. They have a granular, and he'll talk about it. Most of the publications are granular data sets that he himself has delivered. So he delivers the babies and then he delivers a publication. And so it's really a unique attribute. Yasser loves to talk about the phenotype of the obstetrician within MFM. I think nobody embodies that more than Nady. And his practice has grown so much that we have many of our former trainees have gone on to work with Nady, including Sam Doe, who's still in the practice, and then Mariam Nakvi, who used to work with Nady and his group. So I can go on and on with superlatives to Nady. I'll stop. I'll just say one more thing. Nady's currently in Cancun. That's how much he's either drunk or dedicated to joining us. So thank you for taking time from your vacation, Nady. Really appreciate it and really excited to hear what you got to say. And how do you collate 75 publications on twins into 30 minutes? I'm intrigued. So the floor is yours.
Wow, thank you for that. And by the way, in case you're curious, to me, Dr. Blumenfeld is Yaya. So if you hear me call him Yaya, that's what it is. My wife and I spoke today midday, and we revolved my margarita schedule around this talk. So I am not currently hammered. I am totally straight, ready to roll. Yes, I've known Yaya since I was an intern. That was the peak of my career, and it's descended slowly since that point. But yes, we worked together. People confused us all the time. We were the two men with short hair, and so that was enough to confuse us. But I'm really honored to be here. My grandfather always wanted me to go to Stanford undergrad. I didn't, I couldn't get in there, and this is basically the closest that I've come to that. So this is a big honor for me, and he is very happy with me right now from above. All right, I'm going to share some slides if I can. All right. Someone give me a thumbs up if this worked.
Perfect.
Yes.
Good.
Okay, good. So, yes, I'm going to talk about delivery of twins. I plan to finish early, so we have time for questions. It has been a passion of mine clinically, as well as from a research perspective. The gratuitous photo of me, Yaya, and Andre, my other partner, is as you can see. And I'm really excited to be here. Okay, so a few disclosures. So I am the father of twins and two other kids. And yeah, that's also my only financial disclosure that all my money goes to my children. And so there we go. Now, my twins were born by C-section. They were both preterm labor, 35 weeks. So I don't have any vested interest in that sense. And I did not use AI to create these slides, which tells you mostly that I'm old. Okay, so what I'd like to do today is we're going to go through some literature regarding twin deliveries, specifically related to the likelihood of a vaginal delivery of twins and then the safety. Then talk about sort of how we do, what's our protocol, at least for management of twins in labor. And then if y'all are interested, to describe a strategy to increase vaginal delivery of twins, either by you guys or anywhere. So, as I'm sure you all know, twins are ballpark 2% of all live births in the United States. And the C-section rate for twins is very, very high in the United States. Let's call it 75%. It ranges, but that's a good ballpark number. Pretty high. So, why is that? The first is that most of the twins in the US are not even going to try to labor, they're just going to have a planned C-section. Then, amongst twins who are laboring, somewhere between 10 and 50% will have a C-section in labor. And the third reason is to have a C-section of the second twin. Some people call it vaginal cesarean. Some people call it the vaginal delivery, which is basically probably the one that most patients would not want to have. Meaning, I guess there are some exceptions, but I think for most women, if they ended up with a vaginal delivery of first and a C-section of the second, they probably prefer to go back in time and just have a C-section of both. I guess not universally, but I would say probably. And in the US, the rate of that is about 5 to 10%. So, knowing that, how should we be delivering our twins? So, in order to answer that, we have to really look at two separate questions. One is the success rate, meaning if you try to deliver twins vaginally, what's the chance they'll both deliver vaginally? And the second is the safety. If you try to deliver twins vaginally, how safe is it? And this is really a very similar or parallel conversation we have with a lot of things in obstetrics. For example, TOLAC or VBAC, right? When you're counseling someone about TOLAC, you're going to be talking about the safety of it and talk about, risk of uterine rupture and rates, but also the likelihood of a delivery. Meaning, if you believe that their TOLAC success rate or their VBAC rate is only going to be 10%, they're going to be less tolerant of a 1% risk of uterine rupture than if their chance of success is over 90%. I think that's logical, and I think that's how most people will look at it. So you have to really go into both of these. So in terms of success rates, success means different things to different people. This slide is mostly gratuitous to tell you that I'm a big Chicago Cubs fan. But prior to 2016, right, growing up as a Chicago Cubs fan, for me, the last time that the Cubs had won a World Series was 1908, which is before even I was born, right? So that was a very, very long time ago. But interestingly, if you had asked most Cubs fans, they would have been quite satisfied, even though we knew that our team was terrible, even though that we knew that we were never winning a World Series. And there was actually research done on this. There was actual research done on this as to why. Like, why were Cubs fans happy? Why did the Cubs generate large audiences to their games when they were awful for over 100 years? And it's because the Cubs provided something other than just winning, meaning going to Wrigley Field, going to a ball game, sitting in the sun for a day game, having an old style brew or whatever it is. Everyone loved that. And so Cubs fans were generally very happy. And so when we look at success, obviously there's the rate of vaginal delivery, but we have to keep in mind success means different things to different people. Obviously, as obstetricians, healthy mom, healthy baby is sort of what we think of as success, but you have to sort of just keep that in mind. So there are three options when someone's going to try to deliver twins. The first is both twins deliver vaginally. Generally considered success, gets my happy emoji. The second is a C-section of both twins. Now, I don't make that a sad emoji because a C-section of both twins is not a bad outcome. If the mother does well, both babies do well, winners all across the board. As I said before, I think the combined vaginal cesarean delivery is you could end up with a healthy mom and two healthy babies, obviously, but I don't think that's really what we're thinking of with success when we're doing vaginal delivery of twins or any delivery of twins. So how are we doing? If you look across the world, and these twin C-section rates are very rough, the numbers out there are wild, like trying to get this data is not easy. But in the US, we have approximately 75% of our twins are going to deliver by C-section, and somewhere 4 to 8% are going to have a combined delivery. In Canada, their overall twin C-section rate is lower. They're about 50-50, but their combined C-section vaginal is similar. If you go to Ireland, sort of similar to Canada. Netherlands, similar. The C-section rate there is skewed because those are amongst people who labored, not amongst all twins. The only ones who seem to be really winning the gold medal here are the French. Their rate of C-section in the literature is about 21% of all twins who labor, and their rate of combined C-section vaginal delivery is less than 1%. So the question is, what the hell are the French doing, right? What's going on there? And so if you look at the French studies, they describe this concept of active management of the second twin, which is basically if the second twin is breech, you deliver at breech. And if the second twin is vertex, not always, but frequently, you're going to do internal podalic version, which is flipping, for those who don't know, flipping the baby from vertex to breech, and then doing a breech extraction of the second twin. And this is really important because having malpresentation of the second twin is typically the reason twins are going to have a scheduled C-section or a combined vaginal cesarean. And since most of us in the US are not doing a lot of breech deliveries, we're not really skilled or trained at delivering the second twin as a breech. And so if you look at the French data, the fact that they do this indicates how important it is for those outcomes. Now, people say, okay, well, if the second twin is breech, why didn't you just do like an ECV and flip it to vertex? And you can, and that has been described. The success rate is not terrific. It's about 50-50. And if you look at that compared to breech extraction is more successful in terms of getting a lower C-section rate and one done for fetal distress. So it's not ideal to plan to turn the second twin to vertex. So, okay, some people will say, fine, I'm not going to labor vertex breech twins, but I'll labor vertex twins. It sounds good, but number one, you're going to be excluding a lot of people from laboring. And even when you do labor them, after you deliver the first twin, it's really annoying the second twin to deliver vertex because sometimes you have 15 minutes, 20 minutes, an hour, whatever it is, trying to get that second baby out. And there's also an increased risk of morbidity during that time. You could have a cord prolapse, you could have an abruption, you could have a fetal heart rate deceleration. And if you have an emergency, you don't really have options to deliver twin B unless the head is low enough that you could do a vacuum of forceps. So you end up, if the baby's at 0 station and you have a cord prolapse or an abruption, you end up doing a C-section. And as we all know, if you labor vertex twins, the second one doesn't always come down as vertex, and you end up with a second twin breach, and now you're doing a C-section on the second twin. So what would be ideal? If you labored all twins, or at least twin acephalic, and again, you sort of do what the French described. You do breech extraction of the second twin, or if you need to, an internal podalic version and breech extraction. So the question is anybody doing this besides the French? So I'm going to take you back in time, 2007. At the time, I was a third-year MFM fellow, and I had just signed my contract to work at MFM Associates in New York City, which was a group at the time of 4 doctors, 2 MFMs, 2 OBGYNs. And this, I guess, editorial or review came out in the Green Journal, written by a guy in Wisconsin who was a very, very skilled obstetrician. And he was talking about delivery of twins. You can look up this review article from 2007. It's really terrific. And he wrote about internal podalic version, that it's absolutely contraindicated. This is in the Green Journal, because it's dangerous and no one trained after 1970 has any idea how to do this. And so I read this, and then I was speaking to the guys, the 4 doctors I was about to join, and I said, wait a second, don't you do this? They're like, yeah, we do this all the time. And I said, well, this guy said that no one knows how to do it. They're like, I don't know, we all know how to do it. We do it a lot. I said, you should really publish this. And they said, great, why don't you publish this for us? So that led to probably my favorite publication, probably ever, in my career, which was Active Second Stage Management of Twin Pregnancies in the US. And this was from 2010. Basically, I looked back to 287 twins delivered 2005 to 2009, which is basically all by them. I joined in 2008, so maybe I participated in some of those deliveries. And where they did this, they had uniform labor and delivery management, active management of the second stage, including internal podalic version. And we just looked at the outcomes between those who had a planned vaginal delivery and a planned C-section. And there was 130 patients in the planned vaginal delivery at the time, very high rate of vaginal delivery of both twins, 85%, and there was 0 combined vaginal cesarean deliveries. And when we looked at outcomes in the vaginal group versus the cesarean group, they were similar. Again, not a huge study, but at least the data indicated that it was successful and it was safe. And so the conclusions we had at the time is that in a controlled setting, if you deliver twins vaginally, it's safe, usually successful. If you do breech extraction of the second twin, very high vaginal delivery rate and very low combined vaginal cesarean delivery rate. Exact same conclusions that the French had. So then this really got me started into my twin publication career, and we figured we have this database, let's grow it, let's publish the hell out of it, anything we can. And so we did. And one of the things, so I'm just going to highlight a few that I liked. This was sort of looking at the success rate of twin vaginal delivery. So this was 286 women who were attempting vaginal delivery. So this is more than double of who attempted vaginal delivery in the other publication. And similar numbers, 82% delivered both vaginally, 18% C-section, 0 combined vaginal cesareans. And then when we looked at risk factors for C-section, as expected, like for singletons, nulliparity and advanced maternal age. But then we looked at, okay, so those are the risk factors. Are there any people we should be counseling against attempted vaginal delivery? Because it's not worth it. Their success rate is too low. And what we found was basically no. We looked at the 3 biggest risk factors, which were being nulliparous, being over 35, and having your labor induced. And then we looked at every combination of those 3 risk factors, and then we ranked them. And basically, if you had none of the risk factors, meaning if you were a young multip who went into labor on your own with twins, your rate of vaginal delivery was 98% of both twins. And if you were in the worst case scenario, you're in what we call in obstetrics elderly nullip who gets induced, it's still 50-50, which is really not terrible if you think about it. And so in our practice, there's basically nobody, again, unless there's a contraindication or whatever it is, who we will say your chance of vaginal delivery is so low it's not worth it. Worst case scenario, it's 50-50, which in my opinion is not terrible. I'm an optimist. That's how I roll. So 50-50 to me is a thumbs up. So again, if you're doing this, about 75 to 85% will deliver vaginally, maybe 15 to 25 will deliver by C-section, and your vaginal cesarean rate is somewhere either in the 5% range or less than 1% if you're doing breech. Okay, so those are success rates. What about safety? So this was the big study in 2013. So prior to 2013, when we were doing this and we were publishing on it, all of the data, or almost all of the data, was retrospective and was all over the place. You could find retrospective studies that said delivery of twins is safe. You could find retrospective studies that said delivery of twins vaginally is horrible. You could find studies that said it's fine for di-di, but horrible for mono-di. Everything was out there because they were all quite biased, right? As retrospective studies, the ideal people would either get selected to deliver vaginally or they included people who didn't have a chance to get counseled, whatever it is. So this study came out in 2013, really, really landmark, which is prospective, randomized over a long period of time. Very, very impressive endeavor. 106 centers, 25 countries. They had 2,800 women with twin pregnancies, 32 plus weeks, estimated fetal weight, 1,500 to 4,000. First twin had to be had first, and they included dichorionic or monochorionic, and as expected, they excluded monoamniotic. And their primary outcome was for the baby, composite of fetal neonatal mortality or serious morbidity in the first month, and it was exactly the same between the two groups, around 2%. No difference in any secondary outcomes, including fetal and maternal composite morbidity, though interestingly, they did not include cesarean delivery in the composite morbidity. I've never had a baby myself, but in my opinion, if I had my abdomen cut open and sewed closed, I would call that morbidity. And so in the group that had a planned cesarean, that was 100%, and the group, or almost 100%, and the group who had planned vaginal, obviously much, much lower. So it's very interesting also when you look at studies that look at morbidity, they don't put C-section as a morbidity, although, again, I would argue it is because I'm told they hurt. And then the primary outcome was not affected by pretty much anything they looked at. Position second twin, chronicity, where it was done, all these things. They did a follow-up on this 2 years. They'd done more, but the 2-year one was the most impressive with the highest rate of follow-up. And at 2 years of life, still no difference in the groups for death or neurodevelopmental delay, about 5 to 6% in both groups. And this was, they had 2,300 for follow-up. That's pretty much everybody. So for patients with a twin pregnancy and the first twin is cephalic, having a C-section does not reduce neonatal morbidity or mortality. Again, this is assuming that you know what you're doing. So something that comes up a lot is, okay, what about you have a situation where you have twins and they need to be induced, right? That included a lot of people who went to labor on their own, and we all know that's usually better. But let's say you have twins, she's 35 weeks with monodi twins, and now, for whatever reason, growth restriction, you want to induce her. So your two options now are not labor or cesarean, it's induction or cesarean. So we decided to look at this. Kelly Zothman, who was the first author, was a med student at the time, FYI. She's now finishing her MFM fellowship. And we looked at 453 twin pregnancies who were over 24 weeks who needed to be delivered, and they were not in labor, right? So we took out anybody who went into labor on their own. So 212 of them we induced, and the other 241 had a scheduled C-section. And then we looked at outcomes, and we planned to divide them into preterm and term. So in the term group, 37 weeks, as expected, the ones with the planned cesarean, none of them had vaginal deliveries. And in the ones who were induced, 70% delivered vaginally on average, which is great. As you would expect, the blood loss was more for the C-sections than the vaginal delivery. Length of stay was higher, obviously, because they had C-sections. There was no difference in rates in neonatal morbidity that we found in terms of NICU admission or ventilation or either twin. And then in the preterm group, very, very similar. The rate of vaginal delivery was 74%, less blood loss of vaginal delivery. Length of stay, obviously different. And we did see a difference in ventilation rates for the babies. So in the preterm babies who had an induction of labor, lower chance of being ventilated than planned C-section. Again, not a huge study. Hard to know if that's an anomaly or if it's real, because as we know, C-section is associated with a higher rate of respiratory morbidity. So maybe that's real. And so what we concluded is that if you had twin pregnancies with an indication for delivery, you could induce them. High rate of vaginal delivery, this is term or preterm, similar or improved maternal outcomes, and similar or improved neonatal outcomes. And it did not matter how far pregnant they were. Again, they had to qualify for vaginal delivery of twins. Next question about monodi twins, right? Can we deliver our monodi twins vaginally? So we looked at this and published it a few years ago. 2021, so this is retrospective. We looked at outcomes between monodi and didi twins, and then within monodi twins, we looked at vaginal delivery versus planned C-section. So just comparing monodi with didi, amongst those who are planning a vaginal delivery, the rates were pretty much exactly the same. And then we looked just at nullips, the rates were exactly the same. So no difference in vaginal delivery rates between the two. And then within the monodi twins, the ones who had planned vaginal versus planned C-section, very similar results. 73% delivered vaginally, no difference in APGAR scores, cord pHs, NICU admission. And we saw the same thing in terms of ventilation. The group who had a planned vaginal had a lower rate of ventilation of either twin. Again, it could be just small numbers and an anomaly, but it's the exact same trend we saw with the other study, and it does make sense biologically. It's plausible that delivering them vaginally will lower the rate of needing ventilation. So we concluded that monodi twins and didi twins planning vaginal delivery has similar success rates, and within monodi twins, a vaginal delivery similar or improved outcomes compared to planned cesarean delivery. Okay, this is great. Wonderful. Good stuff, Nady. How do we actually start doing this if we want to? So this is our team. You'll see top center is Samantha Doe, who you guys shipped to us, and we're very thankful for that. She's terrific. This slide used to have Mariam Nakvi, is that your said, who we loved, but she didn't love us. She moved back to California. No, I'm kidding. She loved us very much, but she just wanted to go back to California because you guys have a great state. So this is our group of delivering doctors. There's 15 of us. As you can see, we are all over the place in terms of everything. The fellow without a photo is someone who just didn't get us his headshot in time. He just joined. We have a mix of MFMs, OBGYNs. We span everything, age, experience, geography, whatever it is. So this is us. We do this. So what do? We have a very specific twin delivery protocol or guideline in terms of patient selection, all of these things, and we'll go through them one at a time. So the first is patient selection in our practice, pretty similar to the Barrett study from the New England Journal. Twin A has to be vertex, obviously no contraindication to labor. And for us, what we do for the second twin, as long as the second twin has an EFW over 1500 and the discordancy between the twins, the second one is not larger and more than 20%, we're going to be okay. If the second one is vertex, we talk about that it's an option, but we would not do a breech extraction if the second twin was much larger than the first twin, and that's how we define it. And obviously, she has to desire a vaginal delivery. It's not for everyone. Some patients don't want it. Totally fine. If someone wants a scheduled section, we're happy to do it. Next is we specifically sit down and talk to them about vaginal delivery of twins in the prenatal period. One of the OBs who delivers talks to them. We give them copies of our publications if they want it. We give them the option, and then we detail this in the prenatal record, meaning we don't have this conversation when they show up in labor. We have it in advance. In terms of timing, I think similar to many people, our didi twins, we deliver 38 weeks, monodi 37. Obviously, a lot of them have indications to go earlier, but this is sort of our end line. We will induce twins. In our practice, we typically use a transcervical Foley. Rarely we use cytotech, almost never. And then obviously, like everyone knows, a lot of patients. We strongly encourage, if not require, our patients have an epidural in labor. Obviously, we can't require anyone to do anything, but what I basically tell them is if they don't have an epidural, it's nearly impossible for us to do a breech extraction. And if they ask why, I say, do you want me to tell you why? And they're like, yes. And then I basically say, in order to do a breech extraction, I have to reach up, and then I point to my elbow. And I say, I have to reach up to my elbow. And typically after that, they're like, I think I'd rather have an epidural for that. And I think we've delivered maybe 2 patients over 20 years, done a breech extraction without an epidural. Very, very, very unusual. In terms of management of labor, pretty similar. We do monitor both twins continuously. Obviously, IV access, one of us is there. And then basically they're in the labor room. And the second stage, we move to the OR. We go to the OR not so much because we're worried about a section, because again, our combined C-section rate is only less than 1%. It's mostly because it's the biggest room on the labor floor. Um, I tell people it's crazy how many people are in the room for a twin delivery. So there's two OBs at least, obviously house staff, medical students, whoever, two sets of nurses, two sets of P team, anesthesiologist, a scrubbed OR tech. I tell people we bring in a lawyer, an accountant, you know, whatever. We need someone to wash the walls afterwards. It's a lot of people. It's not a candlelit birth in a bathtub. This is wild and crazy. And we warn people about that. Like if they're looking for a quiet, calm delivery, it's tough with twins just because we need all these people there. So what we do is we keep the pit going. If it was infusing prior, we try to get them in because they're an OR table. It's not the same as a delivery. We try to do the best we can to get them set up sort of similar to pushing. It's never exactly the same as a labor bed, but we do our best. Then twin A delivers sort of the old-fashioned way, head first. We'll do, forceps or vacuum if we need to, episiotomy for usual indications. Very unusual that you would need an episiotomy of twins, but whatever. Clamp the cord. Then we go to twin B, right? So this is where the magic happens. So twin B is going to be either breech or transverse, right? So non-vertex, or twin B can be vertex, but really not engaged. It's like way up. You're basically feeling a shoulder. You can pretend that the head is first, but it's not really. Or it sort of plops down into the pelvis, and you're like, oh, this baby's vertex. So if twin B is breech or transverse, essentially we do a breech extraction. If there is Pitocin running, I tell the nurse, please stop the Pitocin when I'm going to do this. And also, this is something we discuss in advance of going to the OR. Now, if twin B is vertex and engaged, then usually we're just going to continue. I usually increase the Pitocin. Almost always after the first twin comes out, the uterus kind of like shuts down. And so rule of thumb is almost always I'm going to double the pit. If they're on a lot of pit, maybe I won't double it, but you go up on the Pitocin. At some point, you're going to do amniotomy, and she's just going to deliver as a vertex. And this will work if the baby is vertex and engaged, and it's unusual that you're going to have that 1 hour time between the babies. That's typically when twin B is not engaged, and you try to do this. But a twin B sort of plops into the pelvis, particularly if she's a multip, and you rupture membranes and she pushes, the baby's going to come out pretty quickly. Now, if twin B is vertex and unengaged, generally that's when this is the big decision point. Is it engaged or not engaged? If it's unengaged and you think it's going to be easier, we usually turn off the pit and treat it like breech or transverse and do internal podalic version and breech extraction. It's unusual that we have to give TURB or some relaxing agent, but sometimes we do. Internal podalic version can be taught. It's really just a breech extraction, but if the head is first, you're using your hands, one internal and one external, to sort of push the head up while you pull the feet down. So in this instance, you sort of take a feel, and it looks like the baby's back is to the maternal left. So if that's the case, your left hand is going to go in and grab the feet, and your right hand is going to sit on her abdomen and push the head up as you pull the feet down, and it just flips the baby to a breech. If the baby were the other way with the back to the maternal right, then your hands would be the opposite. Then your right hand would go in and grab the feet, and your left hand would be on the head. This is one of the situations where you have to be ambidextrous as an OB. You have to be willing to use either hand to go in, because if you're in this situation and you put your right hand in to deliver to get the feet, then you have to cross your left hand over your right hand onto the maternal abdomen, and it's nearly impossible. So typically you feel where the back is, so then you'll know where the feet are, and that's the hand that goes in. Okay, so what if you decided, hey, let's do a lot of this, right? So I would suggest to plan ahead. So let's say you wanted to do this. The first is everyone has to be on the same page. The thing that really seems to be difficult for patients is when they're told, hey, if one person is on call when you go into labor, you're going to have a vaginal delivery, but if the other person's on call, you're going to have a C-section. I get it. Sometimes you don't have a choice, like it is what it is, but it's really, from the patient perspective, that's really strange to say that. So if you're going to do it, pick some protocol. You can email me, I'll send you ours, or you can write your own. It's not that complicated. You just decide this is what we're going to do. Like, this is who we're going to say yes, this is what we're going to say no to, this is how we're going to manage them. Everyone gets on the same page. Again, not too complicated. There's not a lot of disagreement about this stuff. Obviously, standardize your patient counseling, document it well in the medical record so everyone tells the patient similar numbers, similar risks. Find someone who knows what they're doing, right? Every place has someone who knows what they're doing, whether it's one person, two, three, four, the more the merrier, who knows how to do this, including breech extraction. And then this is the key, number 5, because there's only so many twin deliveries out there in every institution. Every time you have a twin delivery, you make sure that there are 2 people who are there, one person who knows how to do it and one person who's learning. If one of those people has to come in from home, they come in from home, right? This is really the commitment. You make a commitment that someone's going to be there for these deliveries and someone who's learning is going to be there for these deliveries. So there's no wasted opportunities. In our practice, we have an on-call rotation and we have a second on-call rotation of like senior or like old people. And we have committed that we will come in for every twin delivery just to make sure that they're covered. So if someone is in our practice and is junior and hasn't done a lot of these, the patient will end up getting what's best for her, and we'll have someone who knows how to do it and someone who's learning so we can train people. And we have trained people to do this in our practice. And then I would encourage everyone to track your outcomes, research quality improvement. And so you could tell your patients, this is our success rate. This is what works in our practice. So as a review, many patients with twins will have a C-section. That's fine. God bless. Again, if the mother's healthy and the babies are both healthy, that's a win. But there are many patients with twins who are good candidates for a trial labor. And for people who work on it and know what they're doing, those patients can have a high rate of vaginal delivery, a very low rate of combined vaginal cesarean delivery, and safe deliveries. And if we don't continue to teach and learn this, it will be lost from obstetrics, which is not good for our patients. I have a podcast, and for those of you who are interested, it's called Healthful Woman. It's free. You can look at it yourself, send it to your patients. We have a lot of stuff on twins, delivery of twins, lots of interesting stuff. That's my plug. I don't get any money off it, so it's not a conflict. I just think it's good for our patients. I'm happy to take questions. I will get out of share screen if I can figure this out.
Thank you so much, Nady. That was great. It looks like Ron Gibbs has a question. Induction of labor. I don't know if you can see the question, Nady, on the chat.
Oh,
Yeah,
let's see.
Nate, that was a great story. Love the series. Love the way you've developed it. This is what we really need in modern obstetrics. So my question is to expand upon your induction of labor in twins. And do you make any modifications for the twin versus singleton, such as the oxytocin dose in view of the larger
Yeah.
radius, and then complications of
Yeah.
induction of labor in twins?
So great question. Thank you. I forgot to mention before that Yair is the one who taught me how to put the O back into MFM, obstetrics. So very good. So basically, for induction of twins, no, we don't really have any different protocol. First of all, the hospital won't let us because, as you know, the Pitocin is the lords of the Pitocin are the nurses. So it doesn't matter what I want to do, they will tell me no. So be it. That's fine. Safety first. It doesn't, at the end of the day, especially nowadays that we're all so kind of liberal with our induction labor lengths, and it doesn't tend to require anything different. And so you titrate the Pitocin to the contractions. So we don't really have to do anything different with the rate. I'll tell you, we did a study, I didn't put it in here, where we published induction of twins versus singletons, and the timing was basically the same. It's not much different, is what I would say for nullips or multips. It's pretty similar, in my opinion. PPH, it's interesting. We looked at our other studies. We had higher blood loss in the C-section group, but we do have a higher transfusion rate in the vaginal delivery group. They're more likely to have a massive hemorrhage, I would say, than twins having a C-section. So yes, on average, if there's no massive hemorrhage, your C-section will have higher blood loss than a vaginal delivery, sort of like singletons, but they're more likely to have massive hemorrhage. So our transfusion rate in twins is closer to like 5% or something like that, compared to, whatever it is in everyone else 1% or 2%.
Great. Love listening to your presentation.
How frequently have we experienced head entrapment, need forceps assistance for delivery? So for twin B, we had, fortunately, I wasn't delivering. One of my partners was, but we had head entrapment twice, one of which was someone who was actually told not to labor because baby B was like 35% larger than baby A, and she was basically told not to, and she said, too bad. And so my partners, Andre and Sam, delivered that baby, had to break both clavicles to deliver twin B, and she named the baby after both of them, just so you know. Twin B is named after Andre and Sam. Okay, that was a success. The other one, I think, was subsequent to the publications. We had one twin who had to have a C-section for twin B. I don't know if it was truly a head entrapment or not. I personally have never had to use pipers for twin B. And the reason is when we do our twin B delivery and we're doing the breech extraction, usually someone from above will give suprapubic pressure to push the head of twin B down and basically to flex it, right? Because if the back is up, which is how you get it, that sort of is like our pipers, and we do that almost routinely. So I personally have never had to do pipers for twin B, but pipers are the easiest of all the forceps to place because they're a pelvic application. You just put them straight on and do it. You don't have to actually like figure out where the head is. Next question. Anomalous fetuses. It depends on the anomaly, I would say. I mean, like we would deliver babies with a heart defect vaginally if they were twin. I mean, spina bifida, we wouldn't, but I don't know if we've even had that. So I guess it depends on the anomaly. Do you use an exclusion for nullip? Seems to have a narrow mid pelvis. I am, I am personally not inspired by my ability to assess someone's pelvis before labor. I've tried it, and I am probably more wrong than I am right in saying, oh, you have a great pelvis, it'll work great, or oh, your pelvis is narrow, it's never going to happen. So I don't rely on that because I think we're probably shortchanging patients when we tell them your pelvis is not good because we know so little about this. And the pelvis changes in labor and the baby's head changes in labor. So the two variables we're thinking about when we examine them are not relevant anymore. Second, remember, twins are usually small, right? It's unusual to have two 8.5 pound babies. The average size of twins is like what, 6 pounds? And so they tend to fit, is what I say, and then once the first baby comes out, they're multips. And so, the second one you're delivering in a multip already. That's how you think about it.
Nady, do you use different criteria, or do you have different thresholds for arrested labor in twins at all? Or do you use the same as single
Pretty
twins?
much the same. And is anyone using any criteria anymore? Isn't everyone just laboring everyone forever now? Isn't that sort of what we all decided to do? Just let him hemorrhage and that's
We'd
it.
love to we'd love to get away from it. We'd love to get away from it. That's a different,
Yeah, I don't, listen, that's a major conversation. And obviously there's so much art and skill that's involved in that more than just looking at a clock. I mean, the more you do this, the more you get a sense of this is going to happen versus this is not going to happen. And so on some people, you're going to call it a little bit early, and on some people, you're going to wait a little bit longer. And again, I think that probably unlike examining their pelvis when they're 34 weeks, I think there is a lot more to be gained when you're managing them in labor and feeling and knowing and seeing. But ultimately, no, I think we try to be very patient with the twins and hope it's going to come. But if I think it's like enough is enough, yeah, we'll call it. So not much different from singletons is what I would say.
Virginia's wondering if you guys do breech deliveries for singletons. I'll tell you a funny
Yeah,
story about that. I know the answer.
not intentionally
Yeah.
is what I would say. We just don't. I mean, all the data shows it's probably fine, but again, it's just everyone will have a heart attack on the labor floor if you're doing this. And it's just, I don't know. We just don't do it. It's kind of a shame.
All right. Nady, you've been so gracious with your time. Back to the pool. Enjoy.
You
Enjoy.
guys are great. I really appreciate it. Thank you all for having me. And
And
it's It's an honor, and you can all make fun of Yair as much as you want, whenever you want. You have my permission.
They had
Thank
a
you so
salmon